Helen Fell's coming.
All right. So here we are. I think we're on there now. Pat, can you hear me okay?
I can, thanks, Chris.
Fantastic. Well, welcome everyone. Thanks for taking the time to join Pat and I to have a discussion around the future of Australia's mental health. This is the first of these sessions that we've done, and one that we're really excited about. So today we're hoping to have a quick discussion with Pat and get his experience around reforms that have happened through time into mental health in Australia, talk through his vision of where it might go, and then kind of share a personal experience that Pat was keen to share about why this reform is really important. Pat, welcome. You're a man that needs no introduction. You have been a mentor and a friend of mine for many years, and it's great to be able to work with you. Perhaps maybe give us a bit of a history of Australians for Mental Health and why you think this organisation needs to exist and why now.
Thank you, Chris, and thank you for hosting this. And it's great to be able to work with you and your team as well on this incredibly important sort of mission. I mean, it is a mission, and that's really why Australians for Mental Health was conceived about 10 years ago, basically in the wake of a national campaign to get mental health on the agenda, which was fairly successful back in 2010, 2011. And we could see, what the missing ingredient was. We've got the logic and the case. Mental illness, mental ill health is one of the top 3 non-communicable diseases in the world. And yet it's the poor cousin in every single country. Something like 2% of health budgets around the world are spent on something that's at least 15 to 20% of the health impact amongst all disease, actually, all illness and disease. So why is that? And it's a massive neglect worldwide, even in high-income countries, and certainly in low and middle-income countries. The Lancet Commission on Global Mental Health showed this very starkly about 2 years ago. This kind of neglect. So the scale of the issue, even though countries like Australia keep chipping in, small investments and certainly stepped forward, oasis in the desert, I always say, but we haven't actually sort of understood what really needs to be done and taken it as seriously. And of course, the other argument is that, this is not an illness that affects the over 50s, or people in the later stages of life. It affects people in the absolute prime of life, young people on the threshold of productive life. 75% of mental ill health appears by the age of 25. And if a proportion of it doesn't get better, like let's say 30, 40%, and is more chronic and persistent or lethal, then it's devastating in terms of its economic impact as well as its social impact. So much more so than cancer, twice as important economically as cancer. Cancer captures 30% of the health budget. We get 7% in Australia. So the kind of lack of logic here, and just basically purely on the basis of emotion, in health funding now, that was what we're seeing. And I mean, we've got plenty of emotion in mental health, but we've got logic and economic arguments as well. And yet, so what's the missing ingredient? Well, how could that situation actually exist? And the reason is because the public have not been mobilized to connect and organize and mobilize in their own self-interest. It's not an altruistic thing alone. It's a pure self-interest issue which has never really been appreciated by the public. And that's what our job is in Australians mental health. That's why it was set up, to make sure the public can be organized and mobilized and supported to demand, equity in healthcare for a major health problem. We've got sympathetic politicians. We've got great advocates. We've got great lived experience people speaking out, very, very courageous and very, committed people, and people, the workers in the mental health sector, misunderstood, unsupported, and placed in harm's way a lot of the time because of the neglect of the issue. So patients and clinicians are really suffering because of this neglect. So why do we tolerate it? So we want the public to mobilize in its own self-interest. Anyone that's tried to seek help knows how difficult it is to get quality mental health care. Yeah, so why do we tolerate it? So that's the mission for Australians mental health, to change that scenario.
It's an ambitious vision, and thanks for sharing that. I'll just, for any attendees, if you have any questions, please feel free to pop them in the chat box, and we'll get to them. Some of the key questions once we've gone through a bit of a chat with Pat. Pat, you've been in the game a fair while. You've seen a lot of things. And you know, when I was coming up, I really looked up to you and what you and you know, a group of very influential people were able to achieve coming into the reforms that happened with Headspace. And I was, you know, really kind of starstruck that this is the kind of reform that people outside politics could impact the system on. And now we see that's an institution, and, you know, there's people that love it and people that don't love it, and it's divisive in its own ways, but there's no doubting that the impact that you were able to achieve politically was quite immense at that time. And I was curious as to what the lessons were in that that apply for the change that we need right now.
Yeah. Well, I think probably something like Headspace was successful because we didn't just go to government with this sort of analysis and of the problem and sort of beating them over the head by saying you've been neglectful. We said, you know, we know that you would like to solve this problem if you could. So here's a potential solution. It's based on our research. It's based on the level of need, and it's based on consultation and input from young people themselves. And it's a possible solution. You know, we don't know if it's going to work, but it's the best guess at the moment. It's the best, you know, best option. Why don't you try it? And we went to both sides of politics, and they both said they'd give it a go. The coalition happened to win that election, and they set up, you know, what became Headspace. The success ingredients were local. All politics is local, so it was in local communities owned by local consortia who bid for and designed the services. So local politicians could see some value for their community and for themselves in the process. It was focused in a hopeful way and an optimistic way on young people. It was holistic, so it respected, you know, the clinical and medical aspect, but it also took a much broader holistic and social view. So we wanted young people to be able to continue their vocational pathways in education and work. It wasn't just about symptom reduction or narrow sort of ways of looking at the problem. And I suppose it had a national brand, you know, and we didn't have any positive brands in mental health, with the possible exception of Beyond Blue in those days. Like you produced one with Hello Sunday Morning, of course, you know, credit to you. But that entrepreneurial sort of spirit and having confidence in a brand, and obviously you've got to live up to the brand. And this is where perhaps the underfinancing of Headspace over the years has caused it a few issues in terms of being able to live up to the brand. But by and large, it has, you know. It could do better, like, you know, like all models that we initiate, like the iPhone back in 2007 is a much less, it was a minimal viable product, but it wasn't the final super improved version. So that's the way we have to think about mental health reform too. So those were the success ingredients. And, you know, critics, if you don't have critics, then you're not actually doing anything significant, I've learned, you know. So if no one's criticizing it, then it's not actually doing anything different. So I'm not worried about that. But and also you can learn from critics. If people can point out some definite flaws in the approach, then we can address those flaws. So we're always keen to learn.
And now I think probably even in the last few years, we've had quite a lot of work done into community consultation. We've got the Productivity Commission, which outlined a variety of recommendations that could be implemented towards the reform that's needed. And then ultimately the Royal Commission in Victoria, which did similarly specifically focused on the state, but the implications are across, you know, across the country. What is the essence of these reports? Like, what is the headspace of now? What needs to be done, you know, and having support from government in November around what changes need to happen immediately?
Yeah. Well, I think the fact that we had both levels of government, you know, one state and the federal government, holding major inquiries into this issue was a bit of a breakthrough. And credit to Alan Fells for making the Productivity Commission happen, and credit to all of us in Victoria who tried for 10 or 15 years to get the state government to kind of admit that the system was broken, which they ultimately did with the Andrews government. And that was that's a unique piece of honesty around the world, that the government would admit that they failed in a major piece of public policy, and they did. And to their credit, they held the Royal Commission. They've implementing all of the findings, and they just put $3.8 billion over the next 4 years into rebuilding the mental health system from the ground up. And so that's their terminology. So the Productivity Commission, basically, the best part of what it did was to analyze the underspend. So we're spending $10 billion a year on mental health care for a problem that's probably, several times bigger than that. We're spending, for just by comparison, 28 billion a year on the NDIS for about 1/10 of the number of people. So the underspend is huge, and they showed also what the cost of that underspend to the economy actually are. It's 200 billion it cost us by underspending on mental health care. So if we increase the spending by a factor of 2 or 3 over a period of some years, we could save tens of billions of dollars, in lost outlays and things like, welfare payments, cost of prisons, homelessness, and a whole range of things, and addiction impacts too. So they did all that great economic work, and then they kind of, in my opinion, just a personal opinion, they kind of, as they say in Ireland, lost the run of themselves. They got into territory they didn't really understand, like design of healthcare, and they tried to cherry pick a few things to recommend, and some of those things they got right, but they failed to produce a blueprint, which they should never have attempted anyway as economists. And so I think it's good not to look at too closely at insisting on they implement what the Productivity Commission recommended in terms of service reform. Although there are some things like IPS, individual placement support, that were good recommendations. But this is where the Victorian Royal Commission covers that base and compensates for that. So if you take the two commissions together, they're good value. So the Victorian Commission produced the best blueprint I have ever seen in 40 years of working in mental health for designing a staged system of care from the absolutely mildest, earliest stage conditions, where very minimal support or expertise is required, right through to the most complex and potentially threatening and disabling illnesses, so it's got a strategy and a model of care for every level, and shows how it could be resourced, with the states basically coming in from the more severe end and the Commonwealth coming in from the milder and more primary care end. But they have to meet in the middle, because we all know that the missing middle, which the Productivity Commission did define, at least 1 million, I'd say closer to 2 million Australians who cannot get access to quality mental health care. It's a staggering number. It's 4 times as many people as are served by the NDIS who are just not able to access care. I get contacted by people every single day of the week who are in that situation. And these are what we can say, I won't use the word quiet Australians, but I would say the silent majority who are the ones that Australians with mental health need to give a voice to.
There's a couple of questions coming in here and that I think pertain to what you're talking about. And as I've been working on this kind of role for the last couple of months, one of the real challenges I think we have is that there's broader systematic change, but how do you bring it back into the individual's experience and the person that sits within the missing middle, or their family and friends? What does an effective mental health system look like? 10 years from now, if we were to implement all these changes, if we, had 1% of GDP invested from government, and we had, the most effective mental health system in the world, what does that look like for someone, dealing with schizophrenia in their family, kind of ongoing challenge that they have? And how does that compare to what we have now? What does that actually, if you could paint a kind of journey for us, I think that'd be really helpful.
Yeah, sure, Chris. I think this is where the Victorian model comes in. And by the way, you mentioned GDP. the loss of GDP that's explained by the neglect of mental illness is 4% of GDP. So we lose 4% of our GDP, which is twice as much as NATO spends on armaments. We lose 4% every year. So even if we spend 1% to save that, that would be a very, very good investment. So that's our target, isn't it? Aiming up closer to 20 billion instead of 10 billion. So, but what would it mean on the ground? Well, I think it would mean, you know, you would know how to recognize, you know, when it's not just a bad day or just a problem in living or a bit of stress. And it was a need to actually seek help. You know, you would actually be able to recognize that. So you'd have a much more mentally literate community. And we're getting there with that, actually. We're getting a lot better, I think, especially for the common mental health problems like depression, anxiety, much less so than for psychosis and, you know, eating disorders and other more complex sort of disorders. But so recognition would be one thing. Then you'd go to a primary care platform of some sort, whether it be Headspace or it would just be the local GP, or maybe just the school mental health professional, you know, or counsellor, wherever it would be. Either you would go or someone close to you would recognize that you were struggling and actually help you to get there. And there you might be met in a modern mental health service by someone with lived experience, a peer worker or a volunteer who actually would really empathize with what you were going through and also like be a source of trust, you know, if I can put it that way, to help you over the threshold, because it's a big step to seek help for mental health care still. And then once you got in the room, you know, or in the place where you were seeing someone with expertise, like a trained health professional or mental health professional, that person would be compassionate, they would be skilled, they would know how to, you know, engage you and give you confidence in what was going to happen, and also have the skills to begin helping you right at that first contact. Because sometimes you get assessed to death, you know, and then kicked out anyway, or there's no pathway. So assessment and treatment have to begin right at that first contact if you're going to engage and help that person. And then the person would be sort of I hate the word triage because that's usually a way of keeping people out of services, but that you'd be facilitated the right level, intensity, and sophistication of care that you would need. So, for example, if it was an emerging psychotic illness like schizophrenia, you would go to a team-based care that would have the expertise and to deliver the best possible evidence-based care, just like you would with cancer. If you go into the hospital with a breast lump, or if you go into hospital with chest pain, you immediately sort of track to the person who's going to be able to, you know, proactively treat that so it doesn't get worse. That's what we mean by stage care. Finding the problem early, and then, you know, doing everything you can to prevent it extending or progressing to something much more complex and disabling, and that would, so it'd be a tiered sort of level, but not waiting until the person gets sicker and sicker like we currently do, and responding proactively, and also, you know, in a way that allows the person's fears and views to be taken into account, like a shared decision-making type approach. And of course, also, if we're thinking futuristically, we'd like to have better treatments. We'd like to have much more attractive forms of psychological treatment. For example, what we're doing here at Origin is powered by, you know, virtual reality. So it's not just sitting in a room, you know, in a fairly linear way doing CBT. It's actually bringing it to life with technology. We'd also have digital mental health as part of the offering as well, in a broader sense. And we'd have new medications. It'd be great if we could finally engage the pharmaceutical industry back into mental health. People demonize them and they say that they're exploiting, you know, people with mental illness. They've actually disappeared. They're not involved. They're not actually engaged in research anymore. So we actually need that, like we do in cancer. We need people discovering new treatments, and safer ones, you know, with less side effects, and ones that are more effective than we currently have, because a significant proportion of people don't respond to the current treatments that we have. So all of that is what's part of the future, but that needs respect for mental health, respect for investment and growth.
There's a couple of questions coming in here around, and I'll group them together because it's around really collaboration and working together as a sector. And I mean, in any sector, there's always going to be different opinions, different ideas, and different histories that people have. And there's kind of two questions here. One is around how do you have a more effective kind of service delivery, like when there's these different kind of silos of services being delivered, and particularly in primary care, and then going into tertiary care, and that kind of chasm that exists. And the second question is around, well, how do we as a sector advocate better together? And what have you seen that has worked well? And both really kind of talk to the challenge of collaboration across the sector. What have you seen work well, and what have you seen not work as well?
Yeah, they're great questions. I suppose, the current situation is very fragmented, isn't it? And the primary health network idea, where the commissioning's devolved, locally, we have competitive tendering for the scarce dollars that are there, just fragments the system even further. So what we need to aim for is integrated care. That means team-based care based around a single location, like a hub, this concept. And the government is actually moving towards that, both state and federal, which is great. They have actually listened, because currently what happens to people is that they have a GP here, they get referred to maybe a psychologist over here, and maybe a psychiatrist over here. And if they can get access, but those people don't work for the same organization, and they don't necessarily even talk to each other properly. So it's really up to the parents or to the person themselves to actually coordinate the care and organize it. And it's very challenging, especially if you're not well. I mean, and that's probably a problem with the whole health system, not just mental health, that it's done in that way, in that sort of Medicare funded issue. And I noticed some of the questions are talking about the co-payment problem, where the co-payment puts care out of reach for most people, actually, because it's not like seeing maybe a gastroenterologist or a diabetic physician as a specialist. When you see a specialist in mental health, you have to see them quite often, and therefore those co-payments mount up. So that's another barrier. So fragmentation, financial barriers, those are problems. And so the solution then is to have these integrated care hubs that have a whole range of services in the one location, and include things that aren't even clinical, like financial services, perhaps housing, vocational services, and other things that people are impacted because of mental ill health. And legal, I'm not sure if I mentioned legal, that's another thing that people often have a need for. And making sure their physical health is looked after as well as their mental health, because even though they might be seeing GPs, we still know that people with mental illness die 15 years earlier than everybody else from medical conditions which aren't, prevented or treated. So holistic care is what we're aiming for, but affordable care. I mean, the Americans brought in their Affordable Care Act. We need an Affordable Care Act in Australia to make healthcare not a two-tiered system.
Another question that's come through is, and it's one that I've seen a lot in talking to people about this issue, is around the challenge of engaging carers and families around the person that's going through it. How do you see a system better responding to the needs of the carers and being able to support them when quite a lot of burden is placed on them? And what does a kind of system look like that supports that important element in a person's recovery?
Well, when they dismantled the old mental hospital system and basically quite rightly said most people should be living in the normal community and be supported in the community, they forgot to fund the community part of the care, actually, and that meant that so much of the burden has fallen back onto families and loved ones, actually. And yet they've been largely excluded from decision making or involved in the care. Like most professionals just work in a very individualistic sort of model. We've actually turned that around a lot in youth mental health, but in adult mental health, that's still a massive problem. Obviously some families don't get on well together and there's conflict, and you have to be careful about confidentiality and things like that in some cases. But the majority of families actually do get on reasonably well together, and the people who care most about the person with the mental illness are their family members. So to exclude them, the main support system, from involvement in care is a bit of a really dumb thing to be doing, but that's often what happens in the real world. So involvement of families, support for families, recognition of the stress that is. I mean, there's nothing worse. I've experienced it in my own family when someone in my family is not well mentally. It's the most stressful thing that can happen in your family, just about. And is so misunderstood. And often the family gets blamed for why their relative is not well. You know, it's quite amazing, and that goes right back to, you know, traditional psychoanalytic thinking, which basically tried to explain, you know, mental illness purely on the basis of things going wrong in families, which was very unfair to families, actually. So families are part of the audience that we want to appeal to with Australians for Mental Health. I think you've made this point, Chris, that, you know, they can be the warriors, the champions for their family members, as well as, you know, people in recovery from mental illness can also play. They're the other big warrior group that we need. But the warriors have to be able to be constructive and collaborative and solution focused, not seeking, you know, retribution for things that have happened to them. That's not a great way to approach reform.
Well, touching on that, one of the kind of mini campaigns that we're exploring doing is around taking what there was this idea that was created in the UK at a campaign with one of our supporters and teammates, Alicia, and it was called the Museum of Lost and Found Potential, which took objects of that people found that they lost through their mental ill health and objects that they found potential through their recovery, and turned them into, objectified them in a way that helped them share their story and their experience of both illness and recovery. And so we want to start doing that. And so we asked you to share an object that, you know, reflected something that you felt you've lost. And I guess it was really important for me to see this, because it's quite remarkable, the energy that you bring to this sector and this challenge. Your life seems to be triple booked, and you're just an indefatigable person fighting this cause. And I guess we were really keen to hear what is it that really motivates you, and what's the object that, you know, when you reflect on why this work's so important, that that you share.
Yeah, well, thanks, Chris. But I just feel like I'm just one person who is a like-minded person with all the other people that are equally dedicated to making sure this issue gets addressed. You know, so there are so many amazing people that are trying to solve this problem, including many of the people in Australians for Mental Health already. So I do have my own stories, but I actually got into psychiatry before I was aware that mental illness had affected my family. So I began training in psychiatry in my late 20s, you know, having done about 4 years of general medicine, and I was just shocked by the crude and often traumatic treatment that people were experiencing at that time, and how 19th century it was compared to everything else that I had been working in general medicine. So it was really a human rights perspective that I brought when I first got into the area, rather than a personally driven one. But as I'll show you now, I'll share the screen. In my family, and this is not the only person in my family that's affected by mental illness, I'm going to say, but I want to show you a picture of my brother Hugh. So that's him on the right, probably about age, let me think, 16, 17. I went on a surfing trip with him on the north coast of New South Wales. We both learned to surf in Newcastle, surfed together, and then in Sydney at Maroubra Beach, before the Bra Boys, by the way. But we were Bra Boys. So Hugh, my brother, you know, had in many ways like a dream life as a child, but started to struggle in adolescence, and we weren't really sure why. Probably got bullied a fair bit in the beginning of high school. That would have been a key factor, I think. And then began to drift into smoking dope and drinking, but probably driven by underlying depression and anxiety in retrospect. But the addiction became a problem. It settled down, and then it wasn't until his probably late 20s that it came back into the equation, you know, in his 30s, he really became, you know, highly dependent on alcohol, and eventually died at the age of 37 from liver failure. And here's the discrimination that happened in terms of his treatment. Because he had been drinking, and then drinking was the cause of his liver failure, even at the age of 37, they refused to consider a liver transplant, which would have saved his life. And if it was any other cause of liver failure, that he would have been given that opportunity. It's a bit like saying to someone who was a smoker that they wouldn't do a heart bypass operation or a stent because they'd actually, it was a consequence of an addiction. But that's the kind of discrimination that's probably still happening in relation to people with substance abuse or substance use disorders in our health system. So that makes me angry, you know, and the fact that I couldn't actually do anything about that, even though I was a doctor at the time. So he died at the age of 37. So if we're thinking about lost and found potential, I just think about the lost potential, not just of his whole life, but, you know, the other object that I've got there is one of my surfboards, which I had that same brand of surfboard back when I used to go surfing with my brother, McGorry. And so that does represent that sort of lost potential that we had in terms of just enjoying life together, you know, with a common sort of passion. And of course, he lost a lot of other opportunities, like having children and you know, having a productive and fulfilling life, and he suffered a lot, you know, and as well, and was misunderstood. So, you know, that's just a story about my family, and there are probably millions of stories like that across Australia. Every single family's got a story like that, I would say, at some level. And I've got other stories to tell, which I probably can't, because, you know, those people are still alive, and you know, it's up to them to tell the story, really.
And that, I mean, thank you for sharing that, Pat. It's you know, in every family, there's this real experience of loss that happens, and you know, when you kind of lose someone so young, it's such a an important reminder of how important it is to be connected to those we care about, but also the possibility that if we can get people help sooner and more effective and quality care, that perhaps we don't end up losing so much. And so thank you for sharing that. And I'm sure you see a lot of those stories in your work and what you're doing, and they're really important to share.
Yeah, absolutely. And frustration that so many families, even in this day and age, can't get help that would transform the situation, actually, if it was done properly.
So it's yeah, I think the next kind of few months for us, I think, are really critical. We have, as you say, a willing government, like a few blueprints that we can build from. We have really community support around it. What do you think we need to do to work together as a community and as a sector to affect that change so that we can see that future happen?
Well, I think the missing ingredient is the social movement which we're trying to create. I mean, it's not the only thing. Obviously, we have to continue to kind of, you know, be evidence-based, fact-based, and not, you know, I mean, we were on such strong ground, firm ground, in terms of the need and the capacity to make this a lot better. Even if we didn't discover anything new in terms of treatment, if we just made current knowledge available in a effective way, team-based way, to those who need it, we would save tens of billions of dollars, and a lot more people would be living a lot longer and would having more fulfilling lives. So we don't need to, perhaps we shouldn't need to make the case, but keep making the case, but actually trying to help people understand, if they don't actually join up, you know, with the cause, and not everyone has to, but we need a few 100,000 people in Australia to join up and mobilize, maybe through chapters, maybe through local communities, a bit like the solstice movement that that our board members, Stuart and Annette Baker, have set up in Albury Wodonga, with mobilising a whole community every year. Thousands of people come out in the freezing cold. That's what has to happen. Communities need to. When you hear the National Mental Health Commission say we should all connect and that's going to help us get through the pandemic, yes, that's probably true, but we need to connect for a purpose, to make sure that no one will miss out on mental health care. I mean, imagine if 2 out of 3 people with breast cancer were turned away to potentially die from without being offered access to care. If that was happening in any other health area, it wouldn't be tolerated. So why is it tolerated in mental health? That's the question every Australian needs to ask themselves. And what can you do to change that situation? And we need the early adopters. We need the in a way the campaigners. A bit like what we did with marriage equality and other major national campaigns, which did succeed. This is and you formulated a great campaign, which is a 3-year campaign on which we'll judge ourselves as to what progress we've made. And this is achievable. And Australia is the country to do it because we are progressive. And with even the Prime Minister said, look, we've got a long way to go, but Australia is doing better than any country in the world. And I believe that's true. We've got the best ideas and solutions and the blueprints now, but we won't get the investment and we won't get the workforce to actually implement unless the community, creates a sense of urgency about it.
Beautiful. I couldn't agree more. So Pat, thank you so much for sharing your thoughts. And this is the first event that we've done together, and we hope to do several more. And thank you to everyone that's come online and shared your questions and thoughts. We hope to do a few more and have some more collaboration as we go forward. And thanks, Sally, for organising it and moderating the questions on there. Appreciate it. So thank you. And if you are interested in getting more involved in Australians for Mental Health, please jump onto our website, send me an email, get on any of the social media channels. We're at the kind of beginning of a very hard battle over the next few months, and we could use all the help that we can get. So thank you everyone for your time, and look forward to working with you all.
Thank you, Chris. Great. And thanks everyone for listening and being involved.